Our final talk of the day today on our patient program, Dr. Eugene May. Many people are familiar with Dr. May, and many people have heard his talks before, know about what he wants to do, know about what he talks about. And so we're really privileged that he will be here both today and tomorrow for the medical program as well. So we've got a really great show for you right here. And here's Dr. Eugene May.
Thank you. Can everybody hear me okay? Yes. I feel like I'm projecting. Okay. First of all, thank you guys for staying all day and waiting for the end of the day to hear what I have to say about some updates in MS research. I want to also thank the Alaska MS Center for inviting me up. It's always a pleasure to come up here and share with you what I know and what we're doing down in Seattle, and appreciate it. So I'm going to be talking about updates in MS, particularly some research updates, as soon as we get our slides up. And it's kind of a laundry list of what's going on in MS, what are some up-and-coming ideas and treatments and research. And what I'd like you to do every step along the way while I'm talking is interrupt me if you have a question, so that you let me know if something's not quite clear, or if you have some thoughts about it. Invariably, if you have a question, someone else will have a question too about the same thing. So it'll be helpful for the whole group if you stop me. Make sure you raise your hands high enough or jump out of your seat or something like that so that I see you, so that we can, every step along the way, make sure that all the right issues are being covered.
You can go ahead and talk for a moment.
All right. So the first thing we're going to talk about is an update or recent advances in classification of MS. And then we're going to talk more about diagnosis and treatment of MS, ways that we're learning that we can slow down MS, cut down on relapses, slow down progression, ways that we can make people better who already have some deficits or disability from MS, and finally some issues that are floating around regarding where MS comes from, so that we can maybe catch it before it even starts. So just waiting for the slide. Well, I guess the first thing I'm going to talk about is classification of MS. Everybody pretty much knows this general sense of what relapsing remitting multiple sclerosis is, what secondary progressive multiple sclerosis is, what primary progressive multiple sclerosis is. Those are the historical categories of multiple sclerosis. When people have relapsing remitting MS, that's a kind of MS where people get attacks or relapses of symptoms that come on out of the blue and generally get better. They usually get a lot better, these relapses. Sometimes they get totally better, but sometimes the relapses don't improve completely, and a person can have a relapse and not recover completely and be left with certain level of deficit or disability. So people who have just relapses have what's called relapsing remitting MS. A progressive form of MS is a type of MS where a symptom comes on and it just gets worse over time, sometimes rapidly, sometimes slowly, but just progressively worse with time. Some people have a combination of the two. They start off with relapsing remitting MS and then develop progression later. That's called secondary progressive MS. If it's progressive from the beginning, it's called progressive MS. There's kind of a new way of thinking about all of that, and dividing it more into a general sense about whether people have relapses or whether they have progression or whether they have both. So when a person with MS has a relapsing form of MS or MS with relapses, then it would be categorized as MS with relapses, either stable or worsening. So if a person has a relapse and recovers 100%, that would be a relapse with stability. If a person has a relapse but winds up worse off than they were before with persistent deficit, that would be called relapsing MS with worsening. The other kind of MS would be the progressive form. People can have progressive MS that is either progressing or stable. For those of you in here who have either secondary progressive or primary progressive MS, you know that there are times when things don't seem to be getting worse. You might have a period of a year or two, or hopefully more, excuse me, where things seem pretty stable. So that would be considered progressive MS with stability. If you have progressive MS and it keeps getting worse, that would be progressive with progression. And then, on top of that, there are progressive forms of MS with superimposed relapses, either clinical relapses or relapses on MRI. And that would be considered progressive, either active, having relapses, or progressive and inactive, meaning no relapses. So we're thinking more in the lines of either a relapsing form of MS or a progressive form of MS. If you have relapsing MS, it would be considered either stable or worsening. And if you have progressive MS, it would be either stable or progressive, and either with activity or without activity. So you may be hearing your neurologist categorizing things a little bit differently as the years go by. That's a pretty useful clinical tool, but it should be a good research tool as well. All right, thank you. Can everybody see this? Or should we darken things up a little? Can we darken it just a little bit? I don't want you falling asleep either. All right, so this is what I was talking about a relapse, of course, either active or inactive, having relapses or no relapses, worsening or not worsening. Progressive MS, either active or without progression, or not active, meaning no relapses, with or without progression. So the first set of new concepts that we're going to be talking about, or upcoming additions to the MS world, are treatments that we would consider stop MS. They don't cure it, but they help stop it. They help reduce the number of relapses that people get, and they tend to slow down the disability that people with MS accrue. And a couple of these are medications that are either about to enter the market or going to be coming on the market a little bit later, and some other treatments that are a bit more experimental and are a bit further from live that, for the most part, keep MS from getting worse. They don't make it go away, they just keep it from getting worse. The first we're going to talk about is daclizumab, which is a medicine that we're expecting out on the market pretty soon. Yep. Uh-huh. You'll see. It's coming. So daclizumab even has a likely brand name, Zenbrita, I think it is. And daclizumab is a medication that's injected subcutaneously just once a month. So it really has an attractive injection schedule. It's a complicated medicine. It's biopharmaceutical that binds to immune cells and changes the way these immune cells interact with the nervous system. And it's been shown to quite effectively reduce the relapse rate in people with MS and reduce progression of disability over time. It looks like a pretty well-tolerated medicine as well. Main problem seems to be rashes, and there can be some immune overactivity affecting the liver and platelets, but that doesn't seem to be a big issue. So it looks like it's going to be a nice, well-tolerated addition to the over 12 medicines we already have available to treat MS.
Secondary progressive.
It has not been studied specifically in secondary progressive, but as you probably know, most of the medicines we use for relapsing remitting, we use in people with secondary progressive as well. The next one down the line is likely to be a medicine that's called ocrelizumab. So again, it's one of these other monoclonal antibodies. It's a biopharmaceutical medication. It is administered intravenously, kind of like Tysabri is, but every 6 months, so pretty infrequently. So it's an infusion every 6 months. The thing that's so important about ocrelizumab, in contrast to all the other medications that we have available to treat MS, is that it's the first medicine ever, really, to be shown to be effective in people with primary progressive MS. All the medicines that we have so far are really effective in relapsing remitting MS or relapsing forms of MS. Many of them have been tested in people with primary progressive and not shown to have much effect. But ocrelizumab is the first medicine that meaningfully slows down progression in people who have primary progressive. So this is going to be a really nice addition to the medicines that we have to treat people with MS. It seems to be quite well tolerated as well. It's not a big deal, but in its use in other conditions, there have been some increased infections, but in the MS population so far, that doesn't seem to be a big problem. This has been submitted to the FDA. It should be on a fast track, maybe later this year or next year, should be available on the market. So those are the two big new medications that should be available to treat MS that have not been in the MS market before. I don't know if any of you guys in here know about Dilantin or phenytoin. You ever heard about Dilantin? Dilantin is older than I am. It's been around decades and decades and decades, and it's used to treat epilepsy. But, you know, so neurologists are really familiar with Dilantin or phenytoin. Recently, phenytoin was used in a study of people with optic neuritis. Does everybody know what optic neuritis is? So it's an MS relapse affecting the optic nerve. In people who were put on phenytoin when they had optic neuritis, their outcome was better than in people who were not taking it, on the placebo group. So there's something about Dilantin that may help protect nerve cells from the damage that a relapse of MS might cause. Now this is a great, simple medication. It costs like 10 cents a pill. You know, to be able to take something like this to protect yourself when you have an MS relapse and wind up with less problems after the relapse is huge. Now, the main problem is this is just one study that showed this, so it has to be replicated.
Is this the same or equivalent to Topamax?
Well, it's in the same family of medicines. Topamax is a seizure medicine as well. I mean, it's used for other things, just like Dilantin is. But pharmacologically, they're very different, even though they're both used to treat seizures. Yeah. Mm-hmm.
Is there any indication it works on anything other than the optic neuritis part of it?
So far, it's only been studied in optic neuritis. So the next step is going to be use it to treat a wider group of MS patients with different types of relapses and see what it's really doing. It's an easy enough medicine to use. It's just a matter of putting the studies together to really make sure it's justified. So at this point, neurologists are not putting their MS patients on phenytoin in large numbers. But it's such an easy, simple thing to add on. It'd be nice to get more data and see if we can really use this. Now we're on melatonin. So why melatonin? Well, everybody, I think, has an idea of what melatonin is. It's a supplement that people can take at bedtime to help them sleep over the course of the night. But somebody realized, and I'm sure many of you know this, that a lot of MS symptoms are seasonal, and MS relapses can be seasonal. So there was this thought that maybe if we change the way that the brain's clock works, that we can affect people's relapses. And sure enough, in at least a few very small studies, it showed that higher levels of melatonin were associated with a reduced relapse rate of MS. So again, here's something cheap and easy that needs more study, but looks promising so far to see if we can actually help stop relapses in people with MS.
I was taking melatonin, and then I read that it doesn't work with antidepressants. It's the antidepressant, so I stopped taking it.
Well,
Say about that?
you know, it may not work with antidepressants if you're using it for sleep, but if it has some other effect, perhaps in MS, it still may be worthwhile taking to help the MS. But again, this is not ready for prime time yet. This needs more study. Yeah. The good news is there are dozens of medications that are being studied right now to help stop MS and reduce relapses and reduce the accrual of disability. A couple of additional ones I thought I'd highlight. One is called erythropoietin. Everybody know what erythropoietin is, or EPO? It's also called EPO. It's given to help boost your blood count. I think Lance Armstrong got caught taking EPO to get his hematocrit up. But for some reason, it may help reduce relapses in people with MS and lessen disability. A couple studies have shown that, and some bigger studies are getting planned. Idebenone is similar to coenzyme Q10. Coenzyme Q10 has been studied in MS, has never really shown much effect, but there's some early studies with small numbers of patients that are showing that idebenone may be helpful. And like I said, there's so many experimental compounds and some not so experimental compounds, like we've already seen, that may be effective and may enter the MS armamentarium. Everybody's probably heard about some stuff going on with stem cell transplantation in people with multiple sclerosis. Just to review with you what a stem cell is a very primitive cell that we harbor in our bodies in various places. And the beauty of stem cells is that they can turn into just about any other type of cell. If you let them loose, they become whatever the body needs. And you can also direct stem cells using certain chemicals to evolve down a certain line. And in our case, we like stem cells to turn into oligodendrocytes, which create myelin and help coat nerve cells. You can even have stem cells turn into nerve cells and replace dead or damaged nerve cells. Stem cell transplantation, which is getting the most press and the most study these days in people with MS. Oh, I don't want to update now. Bad timing. Most people in MS these days, if they get stem cell transplantations, they're getting what's called an autologous stem cell transplant from their own bone marrow. So you have a lot of stem cells in your bone marrow. They take them out of the bone marrow and inject them back in to your body. There are other types of stem cells that are being studied called pluripotent stem cells. Easier to access. You can get them in the skin. Very little work these days, at least in humans, being done with embryonic stem cells. It's just way too controversial, and fortunately there are other ways of getting good stem cells. HSCT is autologous hematopoietic stem cell transplantation. That's when you get a big dose of chemotherapy to wipe out your immune system, and then you get your stem cells back in to repopulate your immune system. There have been a couple studies now that show that autologous hematopoietic stem cell transplantation actually helps people with MS. It reduces their relapse rate and minimizes disability. The problem is that it's a pretty aggressive procedure and it's potentially quite dangerous. Early on there were some deaths in the people who were getting these stem cell transplants for MS, but as the years have gone by they're getting safer. So with lower risk, there's more thought again that maybe these should be used in people with MS or maybe certain types of MS, particularly highly aggressive, active MS. So the risk is still there, and it's still not clear whether the risk outweighs its potential benefits. So it's not, this is also not ready for prime time. It's only being done experimentally.
Was that risk of the deaths primarily attributed to like infection after they had?
Correct, because when they eliminate your immune system with the chemo, then you're very susceptible to infection. So that's usually the cause. All right. Now, getting a little bit away from treatment, what do we know about other stuff that's going on in people's lives that affect their MS? Well, there have been many studies now that confirm that people with MS who are smokers do not do as well as people who are not smokers. So I think it's pretty clear, and you've probably heard this from your neurologist, that people with MS should not smoke. It's not 100% sure why there is that relation between cigarette smoking and worse neurologic outcome, but it's pretty reproducible. That effect is there. It's thought that there's some component of cigarette smoke that stimulates the immune system, makes it more active, causes more damage in the nervous system, or there also the other possibility, or maybe both possibilities, that there's some sort of oxidative stress that a component of cigarette smoking leaves in the body that makes it harder for the body to repair damage that was done. There's also a lot of research now being done into what's called the microbiome. Has everybody heard of the microbiome? It's this really fascinating concept that our gut is populated by more bacteria than we have cells in our body. So depending on how you look at it, we are more bacteria than we are ourselves. It's true. Well, that's the problem. Some are good, some are bad, and we're not quite sure how it all adds up yet. But those bacteria are immunologically active, and they affect the way that our immune system works. And there are all sorts of autoimmune diseases that look like they can be modulated by the bacteria in our bowel. So that has really far-reaching implications once we have a better understanding of what it's really all about. Because the bacteria that populate your bowel are completely influenced by your diet, your lifestyle, what you drink, what you eat. So at some point, we may be able to modify what's in our bowel to help MS not cause so many problems. So the good news is there's a lot of research going into this, but it's also a little too early to make any recommendations about what to do about it. You have a question? Question? No? So that's the microbiome. I guarantee you, you're going to be hearing more about the microbiome, not just for MS, but for all sorts of conditions. What about genetics? Well, there's a lot of genetic research being done regarding MS, not just who's at risk for MS, but from a treatment standpoint, we want to know when we see a patient, what medicine would be best for this patient. And there are genetic marker studies that are looking into patients genetically who might respond to one category of medication more so than another. So far, those genetic markers are not highly useful, but they may be a little bit useful. The problem is getting the genetic data is still kind of expensive and cumbersome. But once we get a clearer idea about how genetics affects MS and how genetics affects response to treatment in MS, we should be able to see a patient up front, run some sort of genetic profile on that patient and say, well, this patient would do better on medicine X or medicine Y, or maybe even doesn't need medicine, depending on what their genetic profile looks like. Any questions about stopping MS? Because the next step, once you stop MS, is you want to start making people better. I mean, we kind of accept at this point in 2016 that if a person with MS has a certain level of deficit or disability, that they're probably going to be like that at least, and don't expect people over the years to get better with MS. But fortunately, a lot of very smart scientists are thinking about how to actually make people better to reduce disability over the long term. And there are a couple of ways that that's being approached. The most promising and perhaps the next most likely available medication that may actually improve people's function is a medicine that's called anti-LINGO, which is its experimental name. And it's called anti-LINGO because this particular biopharmaceutical works against a chemical called LINGO, or an enzyme called LINGO. And what LINGO does in the nervous system is it stops nerve cells from myelinating. So I think everybody is familiar with the fact that one of the big problems in MS is that nerve fibers lose their myelin coat. So if you have MS and your nerve cell loses some of its myelin, what we're all hoping for is that the myelin reforms and helps protect the nerve cell again so that you can recover from that MS relapse. Believe it or not, though, there are these chemicals floating around in your brain that are fighting that myelin from reforming. And this is just something that's been in our biology for millions of years, but there's something in your brain that keeps your myelin from forming. It causes it to stop at a certain point. So the thought was, if you can block LINGO, if you can block that chemical that's stopping myelination, then maybe you can get more remyelination on a nerve fiber that's been uncoated. So fortunately, there's already been a couple of trials of anti-LINGO. The most recent one was what's called a phase 2 trial, which is a pretty early stage, there we go, phase 2 trial, a pretty early stage human study where people were given LINGO for 20 weeks, and these were people with MS who had optic neuritis. And it showed that in the group of people with LINGO compared to the placebo group, they actually wound up with better vision and better conduction through their optic nerves than the placebo group. And it was really quite well tolerated. Some people were allergic to it. Some people had some problems with their livers, but none of them were serious, and they all completely went away. So it looks like it may be a well-tolerated medicine to help people recover from relapses better and let those nerve cells remyelinate. The phase 3 study is actually going on now. There are 400 people. It's not limited to optic neuritis in the Synergy study. But that's still a couple years before that's going to be done. But again, now, fortunately, we're thinking about how to make people better. It's not just stopping MS anymore. It's trying to get people better again. Here, just to remind us that anti-LINGO is not the only medicine that's being used to help stimulate remyelination. There are many, many others that are being studied, mostly currently at the animal level, and some phase 1 studies as well. Stem cell transplantation is also being studied as a way of trying to make people better. We talked about the HSTC, where we get stem cells to repopulate the immune system. But like I mentioned earlier, you can also get stem cells to develop into nerve cells and oligodendrocytes, the cells that myelinate nerve fibers. There are several ways of generating those. Those are called progenitor cells when you specify their line of development. But you can imagine if there's an easy and safe way of getting progenitor stem cells around nerve cells that need myelin, they'll reform the myelin and help people get better again. This is very, very early in study, mostly animal studies, but that should come to at least human studies in the next few years, almost certainly. And there's some other more simple ways that people with MS can get better and that have been shown to actually make people function better. And this is what I call the wellness lifestyle alternative section. I thought this was interesting, particularly coming up to Alaska, is how can you get better with remote health care? Well, that's been studied, and it really works. And you know, I remember coming up to Alaska up in Sitka, talking to, not Sitka, Soldotna, talking to one of the neurologists there, or the neurologist there, and she was telling us how she takes care of people out on the Kenai Peninsula, way out on the peninsula, and the answer is she doesn't. I mean, because they're out there in the snow on their own for months. So what is that like? Is that really taking care of a person? How do you connect with that person and help them when they're totally remote on their own for such a long period of time? Well, it's been shown that weekly phone calls from a trained social worker or therapist discussing wellness issues, discussing mood, discussing cognition, actually improves people's function and their quality of life. There was a group of patients who were contacted once a week by a trained social worker or psychologist. The other group of patients that they were compared to were just educated at the beginning of the study about psychological strategies and self-management. And this study showed that the patients who were contacted once a week to find out how they were doing, to discuss wellness strategies, actually wound up objectively better at the end of the study period than the group of patients who were just educated about how to be better and feel better. They were better in level of pain, which is fantastic. They were less depressed, and they had improved cognitive function. So even if you have MS and you're out on the middle of the Kenai Peninsula in the middle of winter, talking to someone who's trained and knows what they're doing can help you feel better and actually improve your outcome over time. What about diet? Well, as long as there's been MS, there have been thoughts about which diet might be better for people with MS. And the best answer we have from scientific evidence is that you eat a healthy diet and take care of yourself. That's good for you. That'll be good for your MS. There hasn't been much that's been shown to actually improve the course of MS. But a couple things that have come out in the past few years. One is about short-chain fatty acids. You know, there are all sorts of different types of fatty acids. The bad ones are the, I think, polyunsaturated long-chain fatty acids. Those are the ones in, you know, butter and beef and stuff like that. The short-chain fatty acids you don't get generally directly in your diet, but it's mostly in fiber, high fiber foods. And the bacteria in your gut, it's the gut bacteria again, they metabolize the fiber into short-chain fatty acids. And it's been shown that a lot of short-chain fatty acids promote immune cells that regulate inflammation in the brain and spinal cord. So we don't know yet which short-chain fatty acids are good, which ones are bad. Is this really meaningful in the human population? But meaningfully changing your diet or regulating your diet can have an effect on MS, potentially. And we've always kind of known that. Still not 100% clear how to do it, but it could be that the short-chain fatty acids and their interaction with the gut bacteria may be critical. So we're learning, probably a couple years off from knowing more about that.
Are there active trials going on with diet right now?
You bet.
Okay.
Mm-hmm. High salt diet, there's been studies that show that a high salt diet is bad for MS as well, so you want to cut back. I think it's fair to say people with MS should not have too much salt in their diet. You don't have to have a low salt diet necessarily, but you don't want a high salt diet. That's true in humans. It's also been shown in the animal model of MS. Somehow that may have some relation to genetics and gender as well.
So has there been a big increase in autoimmune diseases since the introduction of antibiotics?
That I don't know. That I can't tell you.
Fast food, the introduction of fast food caused all.
Well, none of that may be helping people with MS. But you know, this interaction with the gut and the bacteria in the gut, it's really complex. And I don't think it's known for sure if it's diet or antibiotics, other medications, you know, whether you're constipated, whether you have diarrhea. I mean, all of those things are going to affect the bacteria that live in your gut. So there are lots and lots of factors. And how the gut microbiome actually affects MS versus other medical conditions, also not entirely clear, because it probably does have a relation with other medical conditions too, and not just the autoimmune ones. I mean, it's compelling to know that you have more bacteria in you than you have you. So somehow or another, we got to be learning about what those bacteria are doing.
Are you suggesting we eat mice?
You eat mice? No, 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 we got to keep the mice in populations high so that we can do studies on them. Yeah. All right, what about exercise? Well, exercise has also been shown in many, many studies now to actually make people with MS function better. You know, it's not just strength, it's not just aerobic health. People who do regular aerobic exercise when they can have improved bowel and bladder function. Their quality of life scores are higher in quality of life surveys. They're less fatigued, they're less depressed. Obviously, you're shooting for cardiovascular fitness and strength, but it's really nice when it has a direct effect on your MS. It has an effect on cognition, too. Can't argue, of course, with just stretching and toning. It's effective in improving people's function. Yoga has been shown in at least several studies now to improve fatigue, attention, balance, and overall quality of life. So these are ways that you can do better, or feel better, and make your MS better. Now, cannabis is a super hot topic. Can you get medical cannabis in Alaska?
Yes.
Okay. What's that?
Can't buy it yet, but it's legal.
Okay, all right.
I get it free.
All right. Don't tell me all that. That's too much information. Yeah.
I live in Washington.
Right.
I know what it's like.
Washington, it's no problem at all. You just go down the street. But the medical cannabis is dispensed separately from recreational cannabis in Washington. So it's quite distinct, and the rules covering each is different. Now, I can tell by the reaction already, I don't need to tell you guys about cannabis and multiple sclerosis. And people with multiple sclerosis have been telling their doctors for years and years and years, it helps. All sorts of stuff. But the medical research kind of lagged behind. And as you know, the American Academy of Neurology is going to wait for the medical research. The MS Society, the federal government, they need to see data. It's not good enough to say, yeah, you know, it's great. So anyway, fortunately, there is some data. It's not huge, but there is some data that the American Academy of Neurology decided was good enough to put out a statement saying that there are certain situations with multiple sclerosis where cannabis can be helpful, and certain preparations of cannabis in particular. And so the statement from the American Academy of Neurology, I think it came out in 2015, it may have been 2014, and it said that cannabinoids have some effect on certain symptoms of MS, particularly oral cannabinoid extract and the branded medication dronabinol, it's called Marinol, reduce spasticity and the pain of spasticity. There's some other studies that showed that Sativex, which is an extract that's inhaled, I don't know if it's inhaled or just sprayed, one of the two, reduces symptoms of spasticity and the pain of spasticity. It also reduces frequency of urination. So studies show that it helps in these certain situations. That doesn't mean it doesn't help people with other symptoms, but this at least has been objectively proven. Now the question is, what do you do with that information? And I think that most neurologists these days accept that there is a role for cannabis in treating MS symptoms and helping people feel better. And in states where you can get medical cannabis, I'm seeing and hoping that more neurologists will be willing to allow their patients to get the cannabis. As you probably know, physicians are not allowed to prescribe it because it's still illegal federally. So even in Washington State, I cannot prescribe cannabis, but I can give people what we call the green card, which states that they have a medical condition that has been shown to benefit from cannabis. So I'm not really prescribing it. I'm just saying they have a medical condition that has been shown to be benefited by cannabis. So those rules may change. Maybe the federal government will legalize it or change its category at some point down the line. But suffice it to say, more and more we're seeing that there's reason that people with MS can benefit from using it. The one caveat, and the one thing that I want to reinforce to you is remember that slide about smoking? Smoking is bad for MS. And we don't know about smoking cannabis. So the general recommendation from your neurologist and from the National MS Society is, you know, if your doc thinks cannabis is good for you, go for it if it's legal, but don't smoke it. So there are many ways to get cannabis these days without smoking it, and it's safest for you if you access it without smoking it. All right, any questions about that? And then finally, we're going to talk about ending MS. Most of the research that is being done regarding ending MS has to do with figuring out what causes MS and trying to block it from the get-go to keep people from even developing MS. And the main issues along those lines are the genetic ones. I mean, there are a lot of good genetic studies that are looking at the markers, the genetic markers in people with MS, trying to identify them early, figuring out what those genes are doing, and try to stop these people from developing MS. So far, the genetic markers in MS are not highly specific for MS. They're pretty widespread in the general population. So we're not sure about how all that works and how the genes that put people at risk for MS work together to create, ultimately, the medical condition. But there's a lot of genetic research being done. There's a lot of talk about vitamin D, which you can see here. We know that people with there's a genetic condition that causes really low levels of vitamin D. Those people are at very high risk of developing MS. We know that kids who have low levels of vitamin D are at increased risk of developing MS. We know that adults with lower levels of vitamin D are at increased risk of developing MS. That means something. We're not sure yet what it means. Is this as simple as us just giving everybody vitamin D and eliminating MS? Probably not. But at least we know that vitamin D is somehow involved. And once we get a better sense of how vitamin D is involved, we may be able to identify people early on so that it never even starts.
Back in the mid-'80s, when I was dealing with MS questions and stuff, they were saying that people that lived in Seattle, Tacoma, that band, were more susceptible to MS. Is that still the thinking today?
Well, I don't think it's
Lack of vitamin D
because of lack of sunshine. Yeah, it's not clear. That may be a factor. You know, we know that the further away that people live from the equator in the first 13 years of their lives, the higher risk they are of developing MS. That may have to do with sun exposure and vitamin D levels. That's true whether or not you live in a cloudy place like Seattle or in a sunny place like Montana. So it's not quite as simple as cloud cover. It's probably more distance from the equator and total exposure to the sun.
And how about natives who getting?
How about what? Native Alaskans are at low risk, and that's probably genetic. The high-risk group are Northern European whites, and the further away they live from the equator, the higher risk they are. But Native Alaskans, pretty low-risk group. But that's totally a genetic issue. Helicobacter pylori is the bacteria in the stomach that causes ulcers. There's some compelling data I thought I would bring up, is that particularly in women, it's been shown that women who get infections with Helicobacter pylori are at higher risk of developing MS. I'm sorry, reduced risk of developing MS. And those with MS who have prior exposure tend to have a less aggressive course of MS too. What does that mean? Again, we're getting back into the gut bacteria, right? So I don't know. We don't know, I should say. But that's something that's worth studying because it looks like there's some sort of role. And then finally, there's some recent studies that show that childhood obesity increases risk of developing MS, getting back to our diets and medications these days. More kids these days are obese than they used to be, and that may be part of why they develop MS when they get older. How that works, we don't know. Is it something in the diet, the microbiome? We don't know. But it's a factor that plays in with a lot of these other factors that may increase people's risk. So that's it. That's a lot of stuff, but I thought I'd throw out at least what I thought were the most interesting things that are coming up. Does anybody else have any other questions? We have like 2 minutes, I think. Yes, Vicki?
So I think it was quite a while ago, but I've always wondered why everybody thought that MS is so different in each person, that one drug fits all. What happened to combination therapy research? Is that happening?
Not much. The biggest study that was done looking at a combination of treatments was a study that looked at Avonex and Copaxone. And it didn't show any particular benefit of using two. I think the problem with MS is that it's so hard to do even one drug study that you start combining two medications and it becomes so overwhelmingly large and expensive that it's almost impossible to do. There are a couple that are going on now. There's one I know with Copaxone and a new medication that's being studied, some with older medications and current medications. So not a lot of combination therapy studies, but that some people are still being treated with combinations. Yep. Yep.
My experience was extreme photophobia last July that led me down to the diagnosis that I have. Have you ever heard of that? It was just like everything was so bright, and even the neurologist I saw said that I've never heard of that before. So I was wondering if you've ever experienced that.
Well, I'm a neuro-ophthalmologist in my day job, and there is a type of MS where people get light sensitivity as a symptom, and the way we know about that is because of the way that the back of the eye is affected with the optic nerve damage or the retinal damage. So it's not very common, but I would say it's not unheard of for light sensitivity to be a symptom of MS. Yeah, but not very common. But suffice to say, you're not the first case. Yep. Maybe one more?
Absolutely.
Okay, if there is one. There you go. Okay, well, there you go. Yeah? Okay, we'll take, yeah.
Okay, minocycline, do you have any studies or any knowledge of that drug therapy?
Yeah, minocycline is kind of like the melatonin, dilantin issue that there have been at least a couple studies that show that it may help diminish relapse rate in people with MS. Is an ideal medicine to use in combination with maybe one of the other MS medicines. But you know, we still need more study on that too. The data so far is just too limited, too few patients, and it's not a compelling effect, but an effect nonetheless. So especially since it's cheap and safe, it's worth considering, but nothing earth-shattering. All right, thank you.